Very much. So at the end of the day, something about ICU organization. I have nothing to declare except that I'm also an associate editor. So we start in the morning, 7 a.m., and you get a sick note of one of your intensivists. And so the question is, do you need a replacement? Is there scientific data that a replacement is necessary? And does this influence patient outcome? And so we have here a very nice study of intensivist physician to patient ratio and mortality in the intensive care unit. This was a retrospective cohort study from electronic healthcare records. It was done in January 2018 to August 2020 in 10 hospitals and 29 ICUs in the US. As you can see, over 50,000 patients, and the primary outcome was the daily intensivist caseload as a count. And they also looked at different ICUs, as I said before. And so here is the median data. It was 11. The mean data was 11.8. And the recommended caseload cap at the moment is 14 because there are some data that then mortality might increase. As you can see here, however, on the graph, that there were a lot of ICUs, or at least days, where the count of patients was above the median and also the 14. And the really interesting thing in this quite big analysis was that the caseload in different forms of analysis, as you can see here, was not associated with mortality. They used it as continuous variable. They used a caseload above the average, that was 11.8, above the 14, as you can see, and it was not modified by the presence of physician in training, nurse practitioners, and physician assistants. So the take-home message from here was that the intensivist to patient ratio in its retrospective analysis was not associated with mortality. However, we have to think about a lot of different things, that the settings might be different, that we have no data out of this study if this changes patient long-term outcomes, so PICS. And as we had heard before, burnout is a very important topic. And of course, if the caseload gets very high, this might be a major problem. The premature caps means that, for example, the 14, there's a very low evidence so far available. So we have to have further and hopefully prospective data on that. So after you have started and you did not replace the intensivist, you get an inquiry at 10 a.m. about a new admission from the regular ward. 65 years old, 10-liter with oxygen mask, SpO2 is 91, and some pre-existing conditions like GOLD 2, diabetes, and hypertension. And therefore, we also have an original paper about hospital factors that influences ICU admission decision-making, a qualitative study of 8 hospitals. So, again, it's a qualitative study, 8 unaffiliated Michigan hospitals, so again, in the US system, and the hospital selection was based on variations across several dimensions. So the ICU admission rates, number of ICU beds, teaching status, and also rurality were different. And the interesting thing is that not only did one-to-one interviews with 87 healthcare workers, no, they only did site visits with clinical observations of the daily work. And they tried to identify hospital-level factors for the ICU admission. So not patient-level factors, but on the hospital side. So the authors concluded out of these interviews that there are 4 themes relevant of hospital factors. On the one hand, the ICU beds, so is there a bed available? And also, is there a high dependency unit or an intermediate care unit or, for example, an emergency department with ICU staffing available? The second and most important theme, of course, was staff. The availability of ICU nursing staff was the most determinant factor, but also the experience and also the comfort of the staff was an important factor. Then, with the theme 3, the transfer options means how was the hospital included in a hospital network? Was it possible, for example, to transfer the patient up to a higher level hospital? Typically, level 2 hospitals try to avoid them, they realized, but it was, of course, an issue. For policies and structures, they realized that official hospital policies were often described as confusing unknown or non-existing. So at 1 p.m. you do a ward round and you ask yourself, what are the determinants of high quality care? And here we had a development of quality indicator set to measure and improve quality of ICU care in low and middle income country from Pari and colleagues. What they did was a Delphi process following the CREEDS guidelines, so from the Equator Network, and it was done between March 21 and October 21. And they used an expert panel, 71 experts, from the CCAA, so the Collaboration for Research, Implementation and Training in Critical Care in Asia and Africa, which represents over 260 acute and critical care departments in 9 Asian and 8 African countries. And the suggested quality indicators were chosen by a scoping review, then existing national registries they had within their collaboration, and one stakeholder meeting of the collaboration. They had 3 voting rounds for the validity, feasibility, and sensitivity and reliability, and then 1 voting round for the priority of the quality indicators. So they had a total of 57 indicators, however 14 prioritized ones, which you can see here, which were sorted in foundation, like patient-to-nurse ratio, process, duration of mechanical ventilation, and quality impacts like ICU length of stay, hospital length of stay, and ICU mortality. So at 2 p.m., you do a research meeting, and you think now, how do you implement such high quality of care? And here we have another original study, the effectiveness of an intensive care telehealth program to improve process quality, the ERIC study. And that was a multi-center stepped wedge cluster randomized controlled trial. And here again, quality indicators were used. This time, the 10 German quality indicators, you can see here smallly written, which have different things like management of sedation, analgesia and delirium, patient-adapted ventilation, early mobilization, early enteral nutrition, and so on. So what they did, it was a stepped wedge cluster randomized controlled trial from September 2018 to March 2020 in 12 hospitals in Berlin and surroundings in Germany, with over 1,400 critically ill patients. And the intervention here was the daily rounds with a telemedical card, as you can see here on the right side, and expert teleconsultation 24/7 available with consultants from the TLA ICU for urgent medical issues, compared to standard of care. And they had 8 co-primary outcomes as measures of performance indicators from this German quality indicators. Secondary outcomes were mortality up to 180 days after discharge, study-related ICU length of stay, and so forth. So, as I said, over 1,400 patients, 400 patients in the control and 1,000 patients in the intervention group. That's because of the stepped wedge cluster design. The demographics were comparable between the groups, and the setting was that the SOFA and SUBS2 was lower actually in the control group on the first quality indicator days. The important results were there were significant improvement in all quality indicators except the first one, which is the multi-professional and interdisciplinary ward rounds, which were quite established and did not increase significantly, but otherwise all other quality indicators increased. However, for the clinical secondary outcomes, there was no change yet, but that was not the purpose of the study. So that will be, of course, the interesting thing. And in Germany now, in the last week, they have decided that they will implement telemedicine centers now in the countries, which will provide or can provide, let's frame it this way, telemedicine for other centers in the statutory health insurance system. So it's getting late. It's 3 a.m. You're cleaning up your things and you think, okay, how much waste do we actually produce here? And as you know, we have a green ICU collection at ICM, and this is one of the studies, circular material flow in the intensive care unit, environmental effects and identification of hotspots. And this was a circular material flow analysis, and that means a systematic assessment of flows and stocks of material within a system defined in space and time, which goes in and out. They used 1 year, 2019. It was a single-center study at one ICU with 56 beds at the Erasmus University Medical Center in Rotterdam, the Netherlands, with nearly 3,000 patients. And they did a material flow analysis, environmental footprint analysis of the materials, and environmental hotspot identification. And as you can see here already, they had 14,000 kilograms of material mass flow per year in. As you can see, a lot of water and then going out sewage, but still 50,000 kilograms of hazardous hospital waste. And I think it's not surprising when you look at this, what we use as products per patient day, a lot of gloves, as you can see, and compressors and liquid medicine then as number 2 and number 5. Followed by surgical masks and syringes. And the interesting analysis they showed then, you can see here, is that there were different usage then of carbon footprint, agricultural land occupation, and water usage. And per patient day, this resulted in 17 kilogram of mass, 12 kilogram CO2, 300 liter of water usage, and 4 square meters of agricultural land occupation. So different impact of the different products, of course, and I think it is a starting point, to think about where and what can we change in the ICUs. So your shift is coming to the end, as well as this day. It is 8 a.m., it is the end of your call time, and so you go out of the hospital and think it's time for some fresh air. Fresh air for intensive care patients in the Netherlands, an example to be followed. So as you can see here, they have a wonderful outdoor facility at the ICU at the Rheinstedt Hospital in Arnhem, the Netherlands. And we know that, green scenery has positive effects, at least on the normal population. For critically ill patients, we have no data yet. But I at least think personally it's really a wonderful possibility. I hopefully think they would also combine it not only with passive transport there, but also to use it as a possibility for early mobilization or rehabilitation. And with that, I would like to finish with my talk, and thank you for your attention.
Thank you very much for this wonderful presentation, especially the last slide that I like so much. Is there any question or any comment for Stefan? We have 2 minutes to discuss with Stefan about all what we see. I have maybe, I just know if a question for you or for Victoria. More recently, we have a lot of pictures in the ICU with the animals of the patient. Mm-hmm. We see some pictures with, I don't know, dogs, cat, horses, cow. What do you think about this? I tried 2 weeks ago in our department to do this. Mm-hmm. Everybody said I'm crazy man to just follow a dog. Mm-hmm. What do you think about this?
So my thinking about this is, when you think about, there's this one study on occupational therapy, which had positive effects, and also some parts of early mobilization effects is, and I said this in the debate today, if you're an intensive care patient and you look at the ceiling, which is white for 24 hours, the delirium is coming and so on. So I think, this change and this possibility to do something differently, and then perhaps also an animal effect, which has to be proven, might just have positive effects by doing something differently.
Can you briefly comment on what is the next step of telemedicine on the ICU? What is, obviously in Berlin there's a lot of experience. So, and what are the next steps and what do we need to achieve? And this summarized in 20 seconds.
Okay. The next step for us personally is to publish the data where we show positive effects on clinical outcomes. And in our COVID data, we have positive mortality effects with telemedicine consultation. And therefore, I believe, what you saw here in the paper, it's about improving quality and discussing with colleagues and improving the care. I think this is the main things we all discuss about. And this is one great opportunity with telemedicine. It's just one example of one component. And at least in Germany, it will be implemented after the decision of the High Council.
Thank you very much, Stefan.
Thank you.